Namaskar dosto, good evening friends. I am Dr. Sanjay Krala, your familiar and friendly endocrinologist, and you're watching Dr. KK's Med Talks. This is Thursdays with Dr. Sanjay Kalra और आज के हमारे नॉन-स्टॉप शो का 807वां 807th एपिसोड है. Let's have the headlines for today. Now, this is something that some people may not agree with and others may be upset about. But the World Health Organization has said that no amount of alcohol is safe for health, no amount. And 200 million people in Europe are at risk of developing cancer. In Goa, there's only one homeopathy medical college and no admissions have taken place for the second consecutive year. So we really need to think about this, each and every stakeholder. Doctors have noticed a post-COVID spike in lung fibrosis cases. तो लंग फाइब्रोसिस एक कॉम्प्लिकेशन है जो लॉन्ग स्टैंडिंग लंग डिजीज में होती है और कोविड में भी पाई जा रही है. इवन दो कोविड इज नॉट ऑल दैट लॉन्ग स्टैंडिंग, यूजुअली इट्स एन acute to subacute illness. In the meanwhile, the United States has extended its public health emergency status for COVID, and researchers there are targeting mucosal vaccines for respiratory viruses. So let's go to our topic for today. आज का हमारा टॉपिक है ट्रांजिशन केयर फॉर क्रॉनिक डिजीजेस. So we'll learn about what chronic diseases are and we'll specifically focus on transition care. अब ये बहुत नया टॉपिक है मेरे लिए and I'm sure we'll all be interested in listening to this, to understanding about this. So let's introduce our guests for today. A warm welcome to Ms. Simrita Chawla from Ludhiana, a promising young research associate. She's completed her master's in clinical research and now is working as transition coordinator and research associate at the endocrinology department in CMC Ludhiana. Warm welcome, Simrita.
Good evening, sir.
It's great seeing you here, and I think on behalf of everybody who is logged in, we feel so happy when we see young India, confident India, and smiling India in front of us. So you bring a smile to everyone's face. So thank you for that, Simrita.
Thank you, sir.
And we also have Dr. Jubin Jacob. Professor Jubin is professor and head of the Department of Endocrinology at Christian Medical College, Ludhiana. MBBS, MD Medicine, and then DNB in Endocrinology. He's known as a clinician, as a researcher, as a teacher, as an advocate, and he's also editor of the prestigious Indian Journal of Endocrinology and Metabolism. Warm welcome, Professor Jacob.
Yeah, Dr. Sanjay, you can see that I'm having a power outage, so my light keeps going on and off, but I hopefully should be able to talk. You might not see me clearly.
But that's fine because this puts in perspective so many things. One is transition
Hello,
from
can you hear me?
darkness. Perfectly, very well. So one is transition from darkness to light. We see that. Oh yes, and we see it again. And the second is this beautiful concept. The Hindi word is jugaad, and the English word is something like improvisation. So irrespective of whatever surroundings you find yourself in, the work must go on. Things must go on. That was Dr. K.K. Agarwal sir's motto as well. So thanks for being with us, Dr. Jacob. We welcome people.
So even if you can't see me, I'm very much here. I can hear you.
Yep. And we welcome people from not only across the country, but beyond as well.
Sorry.
Greetings and blessings to both of you from Dr. N.S. Sharda, sir is senior physician from Ahmedabad, from Dr. Ramesh Pal Singh Pawar, sir is senior pediatrician. Also from Anant Prakash Mishra ji, from Swapna Jain madam from Vellore in Tamil Nadu. Dr. Jubin happens to be an alumnus of CMC Vellore, Swapna ji. Namaskar from Awadh Kishore Rathore sahab. Also Nitin Narula ji has joined us and Ganesh Ambore ji. Bhupinder Kaur ji says good evening, and so does Dr. Pradeep Rawal from Ujjain and MP. And we also have with us Dr. Abid Rahman from Somaliland in the Horn of Africa. So salam, Dr. Abid Rahman, and welcome to the show. Dr. Abid Rahman is a diabetologist, endocrinologist, and internist working in Somaliland. Dr. Jubin, this topic that we have chosen for today, it's a tough kind of a topic. So would you help us wrap our hands around it? What does transition care mean? And what is so special about it for India, for Africa, for Somaliland? So transition care is basically, while we wait for Dr. Jubin's connection to sort of transition. Oh yes, he's back with us. Okay. So what is transition care, Dr. Jubin?
Yeah, so I think I hope you can hear me, and I hope there are no interruptions. But what I can tell you is that we have a lot of chronic diseases, or even what we call congenital diseases, that happen in childhood and that don't really go away. So that means that child or that person has to live with it for the rest of his life. So when he goes into adulthood, he's going to carry the disease with him. He's going to continue having that disease. And transition is a process by which, when he's a child, he is under the care of his mother, he's under the care of his parents, he's not making independent decisions for his illness. So transition is the process by which we make sure that this child with chronic disease, who is being handled, the disease is primarily being handled by his parents, is able to handle this as an adult. So if you ask me what the definition is, I usually say three P's. It's a planned, purposeful transition from what we call a child or a pediatric centered care to an adult centered care. And I think that is the primary process behind this whole transition care. And in endocrinology, we deal primarily with hormonal diseases. So there are diseases like type 1 diabetes, there are diseases like congenital hypothyroidism, there are diseases like congenital adrenal hyperplasia, which is, or Turner's syndrome, which is going to happen, and the child is going to live with it for the rest of his life. And the management has to happen all through the life.
So a planned and purposeful change. These are important words. We welcome Anamika Anuji also. But let's talk more about this. Does this actually happen on the ground? So let's ask Simrita ji. Simrita, you've experienced healthcare from both sides of the table, right?
Yes,
The
sir.
healthcare system. So what has
Yes,
your
sir.
experience been with transition? Is it just a theoretical word, an empty word, or does it actually happen in practice? Did you receive any inputs when you were transiting from being a girl to being a lady?
So during that time, actually, no severe inputs were there. We used to go through this transition period, and I was under a pediatric care, but still my diabetes was handled by an adult endocrinologist. So they would say it is okay and you'll be fine, and but they would not actually understand what I'm going through. But nowadays, since this topic has arisen, and since many clinics have started like observing the kids that how to help them, so yeah, nowadays it's taking place in some clinics. But as far as my experience is concerned, I did not have a good transition period.
So that's candid feedback. Now there are so many stakeholders involved. It's said, and rightfully so, that diabetes is not a disease of the individual. It's a disease of the family, of the community, of society. It's even called a disease of the nation. So there are so many stakeholders involved. What you've said is right, and we take it in the right spirit that things could have been better. But what is it, Dr. Jacob, which prevents us from achieving that? What happens to family dynamics when, let's say, you have a toddler with chronic disease, you have an adolescent, you have a young adult? What happens in the family?
No, I think the dynamics is very simple. When you're a child, you're completely within a family. You do not really have any will, or you don't have your free will. You eat what your mother gives you. Your mother injects you insulin. You may throw a tantrum, you may cry, but you still, your mother will give you the insulin. And then around 14, 15, you have a little space. That means now you can, go to your room, close the door, and say, I'm not going to eat food. And your mother may not be able to intervene as forcefully as she could do when you're 6 year old. And then at 18, you're an adult. Now you are independent. You decide things on your own. But though we say at 18 you're an adult, you're not still completely an adult. You're still dependent on your parents to pay for your insulin. You're still dependent on your parents to take you for checkups. So though you have some amount of independence from your parents, you are still dependent to a great extent on your parents. So it takes a long time, maybe 25, 26, before you're completely independent for the disease from your parents. you are now going on your consultations on your own. So there is this whole group of transition where you're completely inside your family, and slowly you're getting out from the family to completely being independent for your care decisions, whether it is deciding I have to go and see the doctor, or deciding that this is the insulin I'm going to afford. All these things, there is a whole period of time before you decide on these things.
तो जो डॉक्टर जुबिन कह रहे हैं वो ये कह रहे हैं कि इंडिपेंडेंस 18 साल पे आती है, वो लिखत में ठीक है, मगर प्रैक्टिकली अलग-अलग चीजों की इंडिपेंडेंस अलग-अलग एज पे आती है. जैसे 18 you may be independent enough to decide whom to vote for, to decide whether to take alcohol or not. But for the insulin money, you are still dependent upon your parents. तो वो पूरी इंडिपेंडेंस तो ना हुई. Dr. N.S. Sharda sir point out करते हैं that it is everybody's responsibility, once you know about chronic disease, that you are living with it, to learn about it. So the child with chronic disease, the adolescent and the adult also should learn about chronic disease and avoid the triggers so that they can prevent complications. Poonam Bajaj madam logged in New Delhi se. She is a nursing practitioner. And Dr. Utsav Sahu from Delhi. Dr. Utsav is a diabetologist. वो इतनी प्यारी definition add कर रहे हैं. He is adding to the spectrum of transition care. Dr. Jubin, Dr. Utsav Sahu कह रहे हैं कि we have a lot of admitted elderly patients with chronic disease, with diabetes, with multimorbidities, and वहाँ पे भी transition चाहिए. So you are transitioning from an independent adult who was maybe independent in terms of finance, independent in terms of activities of daily living, to someone who is now dependent on other people for money and dependent on other people for ADL, for activities of daily living. तो ये भी एक तरह का transition care है. So thanks Dr. Utsav for opening this aspect.
For those who can't see, I'm nodding very vigorously.
And Utsav, Dr. Utsav, I think you will not be able to imagine what kind of insight you have just given us. तो एक सच्चे दिल से thank you उसके लिए. And बाकी लोग भी हैं, seniors, juniors, and we'd like everybody's input on this. इसको अब हम बोलेंगे the Sahu phenomenon. What's it called, Jubin? The Sahu transition. Okay, that's good.
Sahu transition, ठीक.
But let's come back to Simrita ji. ये जो अभी points raise किए गए, अब definition या परिभाषा जो होती है independence की, तो लफ्ज या शब्द तो दो हो गए, बाइनरी. सी, डिपेंडेंस, इंडिपेंडेंस. एक और वर्ड है जो हम यूज करते हैं, दैट इज इंटरडिपेंडेंस, व्हिच इज इट इज अ हायर लेवल ऑफ एवोल्यूशन. सो लाइक इन द डिपार्टमेंट, डॉक्टर जेकब इज एचओडी, बट ही कैन नॉट से दैट ही इज इंडिपेंडेंट. वो एक इतना लेवल है एवोल्यूशन का. जब डॉक्टर जेकब कहते हैं कि वी आर इंटरडिपेंडेंट, आई एम डिपेंडेंट ऑन सिमृता फॉर सर्टेन थिंग्स, सिमृता इज डिपेंडेंट ऑन मी फॉर अदर थिंग्स, 1 + 1 becomes 11. That is interdependence. ये highest level of evolution है. तो ये जो words तो binary हो गए, dependence, independence. But does everything happen overnight? Is it black and white, or are there shades of gray in dependence and interdependence? How does it work for a child living with diabetes?
So you're definitely right. There are shades of gray. It is not exactly in this age, especially when we turn 16, when we turn 18, we have a bucket list to explore. So we want to do everything. We want our adventure. There's one thing during the transition we don't want is we don't want to be controlled. But there are many factors when we are living with diabetes. They control us. It is like we are dependent on injections, we are dependent on exact time of meal, and we are dependent on the sugar checks and everything. So yeah, it is not black and white. The transition comes constantly. It comes in phases. You start slowly. You start by just taking care of your medications first. Then you start with the taking care of yourself. You actually start accepting. When you start exactly accepting diabetes, only then the transition phase is made easier. So it is not black or white, or it cannot be overturned like in a midnight. You actually have to accept bit by bit. And when you start managing it, then of course it helps.
This is also important insight. ये बहुत ही सही चीज है जो मैडम ने कही है. अगर हम इसे एक्सेप्ट कर लें, तो पहले तो एक्सेप्ट करें कि लाइफ में ज्यादातर कुछ ब्लैक एंड व्हाइट नहीं होता. थिंग्स काली या सफेद नहीं होती लाइफ में. देयर आर शेड्स ऑफ ग्रे इन वर्चुअली एवरीथिंग इन लाइफ. इवन जो डॉक्टर जेकब की जो एम्बियंट लाइटिंग है उसमें भी शेड्स ऑफ ग्रे आ रहे हैं, कभी ज्यादा कभी कम। तो पहले तो एक्सेप्ट करें, दूसरा दूसरे को कम्युनिकेट करें। सो एज पार्ट ऑफ द हेल्थ केयर टीम और एज पार्ट ऑफ द फैमिली, यू कम्युनिकेट टू द पर्सन लिविंग विद क्रॉनिक डिजीज कि बेटे देखो, इट्स नॉट गोइंग टू हैपन ओवरनाइट, इट्स गोइंग टू हैपन इन अ स्टेप वाइज मैनर। तो पहले एक्सेप्ट करें, अंडरस्टैंड करें, फिर कम्युनिकेट करें, और फिर एग्रीमेंट पे आए। तो ये जो एग्रीमेंट वाला कॉन्सेप्ट है, सिमरता जी, ये कितना मुश्किल होता है, कितना इजी होता है? डू यू थिंक दैट बाय नेचर ऑल एडोलेसेंट्स आर रेबेलियस, or
So
they
not
do agree?
no, not all adolescents are rebellious, but yeah, I can definitely say about diabetics because since of course I have also been through that stage. So yeah, we just want to forget it, and we just want to live a carefree life, no, because it is all about you've got that freedom right now at the age of 18 or 21. We started going to college and everything. So yeah, in somewhat ways we can say we can turn rebellious and we don't want anything controlling us. But still, after like once you accept it and you know it is just as normal as your friends living a normal life, then it is fine.
And Dr. N.S. Sharda sir also says that once you understand that you have to compensate for diabetes, you can't cure it. So you
Yeah.
compensate by following a healthy lifestyle and by taking the right medication. So if you keep yourself well compensated, you're fine. And we have with us Dr. Vipin Bandula. He is a pediatrician from Kangra in Himachal Pradesh, and he's smiling when you say that children are not rebellious. So I'm sure he's thinking of his OPD today. अंशु सिंह जी भी हैं हमारे साथ। बट डॉक्टर जुबिन को पूछते हैं, सिमरता हैज मेड इट साउंड सो सिंपल कि कितने प्यार से हो जाता है सब कुछ। Does it actually happen like that in the OPD? The moment somebody turns 18, they are able to take care of everything and
No,
life goes on smoothly?
no,
What happens?
एब्सोल्युटली नॉट। नहीं, ये जो एक तो है कि डायबिटीज मैनेज करना, दैट इज फैमिली के अंदर दे ऑलरेडी नो हाउ टू मैनेज डायबिटीज, बट दैट इंफॉर्मेशन नाउ हैज टू कम फ्रॉम द पेरेंट्स टू द चाइल्ड। दैट टेक्स अ लॉट ऑफ टाइम. You would see even 16-year-old kids who are getting their injections from their mothers, that they have not yet started taking the injections on their own, or 17-year-old kids who need to be prompted to check their sugars before their meals. So ye matlab, though at 18 you say you have independence, it doesn't really happen. There is a lot of information in the family, but that information needs to now come to the child so that the child can become more independent.
So
दूसरी
the
चीज जो
yeah,
कैन यू हियर मी,
right.
दूसरी चीज जो है जो
Yeah.
इस ट्रांजिशन, दूसरी चीज जो ये ट्रांजिशन में है, देयर आर स्पेसिफिक इश्यूज दैट आर वेरी पर्टिकुलर फॉर ट्रांजिशन पीरियड. मतलब लॉट ऑफ साइकोलॉजिकल इश्यूज. 15-16 साल में मेनी साइकेट्रिक इलनेसेस कम अप फॉर द फर्स्ट टाइम. लॉट ऑफ एंजाइटी, डिप्रेसिव इलनेस, ईटिंग डिसऑर्डर्स. वो पहले मतलब 12 साल से पहले वो दिखते नहीं है. सडनली यू हैव ईटिंग डिसऑर्डर्स. देयर आर स्पेसिफिक ईटिंग डिसऑर्डर्स दैट आर specific for type 1 diabetes. One of them is called dibulimia, which is a eating disorder very specific for type 1 diabetes. So ये बाहर आने लगते हैं. Then there are now children who are going to start smoking, who may start alcohol. There are some things you tell them that this is absolute no. But you cannot completely say that no, alcohol is absolute no. Some of them may want to have a small drink with their friends. So you need to teach them how to handle alcohol, what is the amount they are allowed to drink, what they can expect if they have alcohol, they can expect hypoglycemia, they should be eating themselves. So I think you need to teach them safe drinking practices. Then you have this whole thing of driving. Type 1 start driving for the first time. They may get a learner's license by the time they are 16, and they are on 4 times insulin, so they have to be particularly taught about how to be safe while they are driving, whether it's a two-wheeler or they are driving a four-wheeler. Then even now, I think in our country, many teenagers are getting sexually active, so you need to teach them about contraception. And there are adolescents or 18-year-olds, 19-year-olds, 20-year-olds who get married. So you have to give them preconceptional advice. So these are very specific things that you have to cover, have to be covered with all chronic diseases during this period of transition. in addition to whatever ongoing care that they had?
So some of the things that you've said, one, you've identified a bottleneck of information. Over the preceding 2 to 4 to 10 years, the healthcare team has educated the family, but usually that education has been directed towards the parents. So the healthcare team thinks they've done their job, and it's not necessary that that same information has flowed from the parents to the child. So that is one bottleneck. So we have to figure out, we have to reconfigure our communication strategies and our communication targets. That's one thing. The second thing is novel psychological challenges coming up, and then psychological traits. Like you can have an anxious trait, you can have a depressed trait. That's not necessarily a disease. So psychological challenges, psychological traits, and you might end up with psychological or psychiatric illness. Another point you're raising is social issues. Social issues including peer pressure and maybe substance abuse. And then social challenges and requirements like driving. If you cannot drive, you're not independent. But maybe the law doesn't let you drive. So how do you become independent? So these things have to be figured out. So Simrita ji, what's your take on this? Dr. Jubin talked about driving. Does that become a stumbling block or an obstacle for your independence? How do you take care of it? Or do you view it as an opportunity?
So it can be viewed as both as a opportunity. I would say now that I've started driving, I have become independent, and of course, slowly and steadily, I will start going to doctor consultations on my own. I would not take my mom along. So there is one factor that driving has obviously given me independence, but there's another factor dealing with it is like is there is a fear of hypoglycemia. If my fasting is too low, I have to check my sugars before driving, or even there is a fear that during driving my sugar gets low. So I would definitely suggest that obviously every diabetic type, especially type 1 diabetic, should have a packet of juice with them. One more thing I would say that I have done is I have a card in my wallet that says that I'm type 1 diabetic. So, in adverse case, if an accident occurs or something like that, the person knows, and I have an emergency contact number in my phone, and as well as on that card itself, it is written. So one thing that can be done. The second thing, if you like during driving, if you face hypoglycemia, you should always. The second thing is you should always have a glucose meter with you and a packet of juice with you. So if you feel you like, if there is a slightly tingliness also, you feel there is a symptom of hypoglycemia, you should always stop driving and you should park your vehicle at the side and at least test your sugar. So these somewhat precautions obviously you have to take, but yeah, driving does give you independence. But if you're a careful driver, then you're good to go.
So this point is very well taken, and let's reinforce it for everyone. Children and adolescents, not children, but adolescents who live with type 1 diabetes have a right to drive. They have a right to independence, but they also have a responsibility towards themselves, and that
Yeah.
is self-care. So you take care of yourself before you drive, you take
Right.
yourself while you're driving, and just be aware, be prepared for any kind of eventuality. This card that you carry, Simrita, is it in English or Hindi or Punjabi? How big is it? How easy is it to
No,
read?
it's just a small card which is there in my purse at the side zip. So
Hmm.
it is just written diabetes, and it's emergency contact is there. Two emergency contact is there. So the person, if there is something I need help with something or anything, the person knows. So yeah, it is written in English only. Because most people, I think that much they can read. Otherwise, an emergency contact is given, so they can dial if the emergency is needed.
Right, thanks. Manoj Kumar Tripathi ji has also joined us, and Dr. Utsav has a question. So, Dr. Jubin, if you could take this first, and then we take the expert comments from Simrita actually. So, Dr. Utsav Sahu says, we have a young type 1 diabetes boy who is very adamant, okay, who frequently misses his insulin, uh, gets admitted with diabetic ketoacidosis. तो थोड़े से मतलब अखड़ से दिमाग के हैं ये टाइप 1 डायबिटिक वाले जेंटलमैन हमारे यंग लड़के हैं अपना इंसुलिन मिस करते हैं कभी कभी और दाखिल हो जाते हैं कीटोन्स लेके पेरेंट्स ये कहते हैं कि हम कोशिश कर रहे हैं, बट ही रिड्यूसेस और ओमिट्स द प्रिस्क्राइब्ड इंसुलिन ऑन हिज ओन। पेरेंट्स का भी कहना नहीं मानता। तो व्हाट अप्रोच शुड वी फॉलो फॉर दिस पेशेंट? प्रोफेसर जेकब प्लीज।
आई थिंक इसके 2-3 कारण हो सकते हैं। एक तो ये एक पार्ट टाइप की रेबेलियन हो सकती है, जो बेसिकली अपना डिसप्लेजर अपने पेरेंट्स को दिखा रहा है बाय गेटिंग अनवेल एंड गोइंग टू द हॉस्पिटल। दूसरा कारण जो मैंने देखा है, पर वो मैं लड़कों में ज्यादा नहीं देखा, लड़कियों में देखा है कि दे गेन वेट व्हेन देयर शुगर्स इज वेल कंट्रोल्ड। सो ये डायबुलिमिया जो होती है, ये जो ईटिंग डिसऑर्डर में तो नॉर्मली वो खाना कम खाते हैं, पर डायबुलिमिया में जो है वो इंसुलिन कम लेते हैं या स्किप करते हैं विद द इंटेंशन कि थोड़ा वेट लूज करें, और जो कीटोन्स के साथ उनको भूख कम लगे, और वो जो वेट अपनी मतलब बॉडी इमेज उनकी ऑल्टर्ड होती है, तो उन्हें लगता है कि वो वेट गेन कर रहे हैं। तो फॉर दैट रीजन वो हो सकता है कि वो इंजेक्शन कम ले रहे हों या मिस कर रहे हों। सो आई थिंक थर्ड तो फाइनली ऑब्वियसली एक तरीके की शैतानी होगी और टीनेज रेबेलियन होगी। तो ऑब्वियसली हमें पहले चीज तो करनी है कि ये पता करना है कि ये मिस क्यों करता है, और आई थिंक फाइनली मतलब बार बार उसके साथ बैठ के एजुकेट करना ही उसका एक फाइनल वे होगा उसको हैंडल करने के लिए। आई थिंक वन अनदर थिंग इज, आई थिंक वी शुड नॉट go away from taking psychological help. Sometimes we can use tools. I think what Simrita uses is, she uses a scale called diabetes distress scale. तो ये सिंपल क्वेश्चनर है, उसको यूज करके व्हेन वी सी और कि ये लड़का काफी डिस्ट्रेस है विद हिज डायबिटीज, विद हिज इंसुलिन, एंड समटाइम्स expert help like a psychologist might be very helpful to deal with that particular child and see why you may not have all the tools to handle him. Smita may not have all the tools to handle him, but a psychologist may have better tool. And once you tell the parents his distress scale is very high, he needs to meet a psychologist, the parents also might be more willing.
So try to find the reason, कारण ढूंढें, बार बार बैठें, अनेक बार बैठें, और हेल्थ केयर टीम के अनेक लोग बैठें, और अगर नहीं हैंडल होता तो यू सर्च फॉर मेंटल हेल्थ केयर प्रोफेशनल सपोर्ट। डॉक्टर साहब ने एक टूल के बारे में बात की, डायबिटीज डिस्ट्रेस स्केल। एक और टूल है जो इंडियन टूल है, विच इज वैलिडेटेड, इट इज कॉल्ड द ग्लूकोकोपर। सो व्हेन यू आर टॉकिंग अबाउट डायबिटीज डिस्ट्रेस, दैट इज एक्चुअली अ नेगेटिव काइंड ऑफ अ टर्मिनोलॉजी। बेचारा बच्चा वैसे ही परेशान है, डिस्ट्रेस्ड है, ऊपर से आप और उसको कहते हो जी आपका डिस्ट्रेस तो जी 12/24 है या 18/24 है, आप तो जी डिस्ट्रेस स्केल में पास हो गए। सो पप्पू वोंट लाइक दैट, नीदर विल द पेरेंट्स। तो वी यूज समथिंग कॉल्ड द ग्लूकोकोपर, राइट? इट्स अ वैलिडेटेड टूल। इसमें 6 तरह के कोपिंग मैकेनिज्म्स हैं। जितने भी कोपिंग मैकेनिज्म्स हैं उनका तथ्य करके हमने 6 किए। 2 आर नेगेटिव कोपिंग मैकेनिज्म्स, 2 आर न्यूट्रल एंड 2 आर पॉजिटिव। तो इसमें स्कोर आता है कोपिंग। अब 6 कोपिंग मैकेनिज्म्स हैं तो कुछ नेगेटिव हैं, कुछ पॉजिटिव, बट किसी ना किसी में तो बच्चा पास होगा ना, चाहे वो नेगेटिव वालों में पास हो रहा हो, व्हिच इज नेगेटिव थिंकिंग। सो देन सी द टोन देन इन द ओपीडी। आपने ये ग्लूकोकोपर भरा, बेटे देखो यू आर डूइंग क्वाइट वेल ऑन दीज टाइप्स ऑफ कोपिंग मैकेनिज्म्स, but shall we explore other coping mechanisms, like maybe like acceptance, like optimism, and let's try to work on them, right? And let's see what happens. तो suddenly एक बिल्कुल पॉजिटिव टर्मिनोलॉजी, पॉजिटिव टोन आ जाती है ओपीडी में, पेरेंट्स भी ज्यादा प्रोएक्टिव हो जाते हैं, एंड दैट इज वन थिंग आई वुड स्ट्रांगली सजेस्ट। दूसरा, अगर आपको डिस्कॉर्डेंस दिख रहा है बिटवीन सेल्फ मॉनिटरिंग ऑफ ग्लूकोज वाले जो नंबर हैं, SMBG नंबर्स, एंड HbA1c। SMBG बहुत सुंदर सुंदर आ रहा है, वेरी ब्यूटीफुल नंबर्स। HbA1c छत पा रहा है, चांद के उस पार है, इट्स लाइक 12, 13, 14। तो दैट मीन्स कहीं ना कहीं तो गड़बड़ है। सो अगेन यू थिंक ऑफ साइकोसोशल कॉजेस। There can be biological causes. There may be hypoglycemia occurring in between. It might be renal failure. There can be a million things, but do think more of psychosocial. So with this, Simrita,
I just remembered a very interesting kid that I saw a long time back, not a long time back, maybe 4-5 years back. तो इस बच्चे की भी जो SMBG रिकॉर्ड होती थी एकदम परफेक्ट होती थी, HbA1c 12-13 हरदम आता था। तो ऑब्वियसली आई फिगर्ड आउट कि ये अपने आप से ये बना रहा है। उसके पेरेंट्स दोनों वर्किंग होते थे, और मोस्ट ऑफ द टाइम्स ही वाज चेकिंग द शुगर्स ऑन हिज ओन। ही वाज आई थिंक अ 16-year-old बॉय। तो फिर हमने उसको एक मीटर दिया जिसमें रिकॉर्डिंग हो जाता था हर बारी, एंड ही कुड नॉट इरेज इट। वी गिव हिम अ मीटर विद, वी हैड पुट इन द टाइम एंड द डेट्स करेक्टली, and we gave him a meter and said, we'll download the meter when you come. तो 2 महीने बाद वो आया, डाउनलोड किया तो भी एकदम परफेक्ट शुगर आया और HbA1c फिर भी 12 आया. So now we were completely confused. ये कैसे बच्चा जो डाउनलोड करके भी सब हमने. So finally, you know what we figured out? बच्चा ग्लूकोमीटर लेके अपनी बिल्ली का शुगर्स हर बारी चेक कर रहा था, अपना चेक नहीं कर रहा था. He had a pet cat, so he was checking the sugars of his pet cat, and the meter was recording perfect sugars of his cat and not his own cat. So this transition time, you have to think that these kids can be very smart, and they can come up with solutions to almost everything you can think of.
So you can have smartphones and smart methods of glucose monitoring like IPDM, personalized glucose monitoring, cloud-based, but बच्चे actually ज़्यादा smart हैं हमसे. मोहम्मद राशिद जी आपको सलाम कर रहे हैं और thank you कर रहे हैं for a great topic that you have chosen today. And Dr. N.S. Sharda sir reminds us that everybody should keep both sugar and salt for any eventuality, because heat exhaustion is also very common in the Indian subcontinent in summer and in Africa as well. But let's come back to Simrita. Anything you'd like to add? Dr. Utsav ka question tha, how do we handle this boy?
Yes, sir. So first of all, this diabetes distress scale I use, actually it has helped me a lot. So it also narrows down these concerns. Either the kid has a hypoglycemia concern, or they have this acceptance concern. They're afraid of their parents, or they are not satisfied with the doctor. So yeah, one thing, this diabetes distress scale has also narrowed down their concern. The rest, Dr. Jacob and you said, acceptance and actually educating them, counseling with them. Actually, effective communication is one key here which can be used. We actually have to think at their level, what they can do, what extremities they can go, and how actually we can alter their lifestyle according to their terms. So it is one thing, effective communication can be really helpful. Then we can, obviously, these tools are very helpful, and after that, still if it is there, then we can go for psychiatric consult.
So again, Dr. Kalra, I wanted to make a point here. This effective communication is very important. You might think you're a good communicator. I'll just give an example of a 22-year-old who came to the OPD, I think 2 days back. So now this is a girl who has not smiled at me for 3 consultations that I've had with her. She's type 1 diabetic. She has not smiled at me. I know she is distressed. She is unhappy. Her brother, first time her father came, her father's main complaint, she's sleeping the whole day. She doesn't get out of her room. The brother's main complaint is she's now active. She's always sleeping in her room, not getting out. I mean, I thought she was depressed. So I in my way, I tried to figure out what happened, but I could not. But then when she was discussing or when she was talking with Smita, we could figure out that her mother is unwell, quite unwell. So both of them stay in the same room, and both of them are all the time thinking about their illnesses and how they are not going to cope with their illnesses. And, so I could not get that information from her, but Smrita could. So I think this is again something that tells us that the team, there is somebody who would be able to communicate. Or as a doctor, we always think we are very good communicators, but I have realized that many times you cannot communicate, or you're not good at communicating to a certain person, but someone else might be better at it.
The same thing happened today in our OPD. So an 18-year-old girl, she came in after 3 years after COVID from the neighboring state, from a minority ethnic group. And on surface, everything was fine. Glucose levels might have been around 150 fasting and 250 postprandial. So things were fine. Her brother had come from Hyderabad to bring her for consultation, because he said there is nobody else now. I've gone there for work and there's nobody else at home to bring her here. The history that I took was fine. The history that the nurse took was fine. But the receptionist, while she was speaking with the receptionist, she whispered in her ear that I have urinary incontinence only at night. And actually, finally, it turned out to be severe diabetic autonomic neuropathy with a huge bladder with urinary retention. So the receptionist figured out. because maybe she felt comfortable with the receptionist. The receptionist was closer to her in age. Now, the treatment, we needed a single catheterization, but that was not possible with this particular ethnic group. There was just one unmarried boy, the brother, who had accompanied this unmarried girl. So then the next step in communication was to softly and politely explain to the brother, this is the situation. This is the part of the anatomy that we want to catheterize. We will not touch other parts of the body, but you please bring your bhabhi or your mummy along, and you come back soon. So come back as soon as possible, tomorrow, day after, whenever it's possible. So you're right, this thing about communication, and you never know, like, ये ad है, हर एक friend जरूरी होता है, तो healthcare system में भी हर एक person healthcare team का जरूरी होता है. So this diagnosis of urinary retention was actually done by our receptionist, not by us. Let's move on then. Dr. Jacob, all these things you're speaking about, finally, what happens to HbA1c and what happens to complications? Like I just described one girl with autonomic neuropathy. Is this common in your practice?
No, I think this thing we have now known for almost 10, 20 years, ki jo ye transition period hai, that is 16 to 22. In most patients with diabetes in any country you go, whether you go to America, you go to UK, this is the period where they have the highest HbA1cs. Average HbA1c in UK between the ages of 16 to 22 is 9.5. This is a very well developed, highly, everything is available free of cost. But even there, the average HbA1c is 9.5. I'm sure Smrita also had a worst HbA1cs during those age. So in when you are younger, your parents make sure your HbA1c is 8, 7.5. But in this age, number one is they have poor HbA1cs. Number two, as somebody was saying, the child is coming again and again with DKA. This is not just that child, it's everywhere in the world. The DKA admissions are maximum in this age group between 16 to 22. That means episodes per individuals are maximum in that age group. The third thing that unfortunately we have noted is that these children are very hesitant to adopt technology. You would see that kids, your parents putting their small kids on pumps using CGMS, but this group of kids, they do not want something attached to them. They are very hesitant to use technology. After 25, they're very good at technology. But 16 to 22, they're very hesitant to use technology. And finally, I think one of the most worrying things I've seen in terms of statistics is the mortality in women in the ages between 19 to 22 is highest with type 1 diabetes. Among all the different age groups that you could possibly have type 1 diabetes, the mortality is higher. Some of it may be obstetric complications as well. But I think these are a few things that means that this is a serious problem. It's not just a psychological or an adjustment problem. This leads to real bad outcomes, both long-term and short-term as well.
What we have seen is that autonomic neuropathy is a marker of unpleasant outcomes. Finally, this is the single thing that we've seen in our OPD, which tells us, I mean, that it's not a red flag. The entire playground is red now. But we've spoken of problem statements. And Megha Ballaji, thanks you for addressing the issue so comprehensively. Dr. Shubhlata Chetwal, Madam, has joined us from Delhi. Madam is a family physician. Question, Simrita ji, aapke liye solution statement. Looking back in retrospect, with experience from both sides of the table, what better could we have done?
So, sir, but in retrospect, like it would have been helpful if there would have been someone I could relate to. Because every time you cannot speak everything to your family, to your parents, to your doctor, even. Because obviously, the answer you would get is okay, it is fine, it will be okay, you'll pass through this stage. There is no exceptional solution they would say. And sometimes even your parents, obviously as parent, they would want yeah, your sugar should be fine and your HbA1c and everything should be fine. So they would also try, but they would obviously not come to our terms or our conditions. Like they would not be okay, they would not chill. Actually, to put in the term, they would not chill. So yeah, if I could have a friend or someone who could actually relate to my situation, it would definitely have been helpful. or my parents could have understood that it is fine for sometimes if I throw tantrums, or I have frustration and I just don't want to check my sugars and I just want to be free. I think the parents also should be counseled sometimes, because they're too strict and the child becomes too calculative. Like either they get too conscious or they get too carefree. So I think sometimes the parents should also understand what the kid is going through.
So, a few things coming across from you. One is follow the middle path of moderation, not too much of strictness, not too
Yeah.
much of leniency, and that is what Lord Buddha has also taught us: follow the middle path.
Yeah.
Second thing is you wanted a buddy, someone you could relate to.
Right.
So, in obesity circles, we speak of barrow buddies. Like, for example, now my barrow buddy is a person called Dr. Munish Dhawan, and he's a pediatrician. So both he and I are in the same BMI bracket, though I'm a bit ahead of him. So when we are together and we begin speaking with each other about each other's breakfast, lunch, dinner, and about each other's middle-aged problems, then I think actually our weight comes down slightly. We behave better at the lunch table. And when he goes on vacation or something and then he stops talking to me, then both our weights go up. So you need a barrow buddy. And I think what you are saying is you need peer support, a gluco buddy
Yeah.
from someone who can understand. Dr. N.S. Sharda says that you means the healthcare team should also be able to speak in the person's dialect or mother tongue. So each and every dialect is different. Hindi itself will have 1,000 dialects. So if you
Right.
are well versed with what the patient is saying or conveying, then you can do a better job. Dr. Jubin, Simrita just talked about being too calculative. So there is this term called orthorexia nervosa. What does that mean?
Yeah, so I think some people, I mean, in many chronic diseases, you have a lot of dietary restrictions. And for good health, also, now we talk about good foods which are not so great. But I think sometimes you can get so involved in this good food thing that it actually becomes a psychological problem. You will refuse. Suppose I mean, you are following a certain kind of diet and you don't find that kind of food at that particular moment. You refuse to eat anything else. So it can have it can. I mean, it's a term that is used for a psychological distress with too much adherence to what is perceived as a good diet. So again, I don't think in transition we have that problem, but I think once it's usually a problem after 25, because then they become very conscious and they may, be too rigid about their diet that they start harming themselves.
So orthorexia nervosa means an excessive focus on the right food, the right everything, and on being right all the time, which may not necessarily be correct always. I am reminded of this song by a very famous Punjabi singer, Satinder Sartaaj. And what he says is, सब कुछ जो मुमकिन होता है वो मुनासिफ नहीं होता. सब कुछ जो मुमकिन होता है वो मुनासिफ नहीं होता. Everything that is possible is not necessarily appropriate. तो मुमकिन है कि दिन में 12 बार शुगर चेक करो. Certainly it is possible. But हो सकता है मुनासिफ ना हो. It may not be appropriate. मुमकिन है कि हम आपका HbA1c 5.1 पे ले आएं. It is certainly possible. But मुनासिफ नहीं होगा. It will not be appropriate. So this beautiful song by Satinder Sartaaj, and I think that is something that many of our children with type 1 की तो बाद में बात करें, उनके पेरेंट्स की बाद में बात करें. We needed ourselves as well. सपना जैन जी कहती हैं वेलोर से कि ये मुमकिन भी है और मुनासिफ भी है कि कैरिंग कार्ड विद इमरजेंसी कॉन्टैक्ट नंबर. तो इट इज पॉसिबल एंड इट इज अप्रोप्रिएट. और ये अकेले बच्चों के लिए मुनासिफ नहीं है, टाइप 1 डायबिटीज के लिए मुनासिफ नहीं है, ऑल्सो फॉर सीनियर सिटीजन विद कोमॉर्बिडिटीज. तो अगेन थैंक यू स्वप्ना जी फॉर दिस. एंड डॉक्टर जुबिन इज वन ऑफ द लीडर्स इन जेरियाट्रिक एंडोक्रिनोलॉजी इन द कंट्री. तो ये भी एक चीज हम ऐड करेंगे. पीपल विद हाइपोनेट्रीमिया, पीपल विद हाइपोथायरॉयड, senior citizens in general, they should have these emergency cards with them in their wallet or in their purse.
I think one thing that now we have with most Android phones is it does have a place where you can put your emergency contacts, your emergency diseases, your blood group, and these can be opened without having your fingerprints or your this thing. So anybody can open and see those things. So I think we have to be more educate people about using their Android phones correctly. I think that's one place where all this information can be stored properly.
Another very good idea. So thanks for that, Dr. Jubin. अब ये सतिंदर सरताज जी आगे हमारी डिस्कशन में मुमकिन और मुनासिफ, तो अंशु सिंह जी पूछ रही हैं कि व्हाट इज द मुनासिफ HbA1c, व्हाट इज द अप्रोप्रिएट HbA1c, डॉक्टर जुबिन, फॉर पीपल इन डिफरेंट फेजेस ऑफ लाइफ.
So I think I mean, whatever the lowest you can achieve without much distress, without causing unwarranted hypoglycemia, is what is the munasif HbA1c. So pre-puberty, I would be very happy accepting an HbA1c of 8%. Post-puberty, the complication risk starts going up post-puberty. So then we would like to keep it as close to normal as possible. But we know that between, let's say, 14 to 18, it's going to be almost impossible to get a perfect control, because these are kids who are going through 10th board exam, 12th board exam. There'll be so many things going on. So I'm happy if they keep it 8.5. That's fine with me. But it is different for each child. It's not the same for each child. So as close to normal as possible, but I can accept 8.5 during those adolescent years. But after 18, I think we should focus on getting everybody to around 7% and start teaching them about long-term complications and things like that.
It depends upon the turbulence also. They are turbulent years. अगर बहुत ही turbulence है psychosocial, तो और ज़्यादा turbulence add ना करें. Don't increase the focus on getting an HbA1c in this line of 6. थोड़ा सा relax कर दें. And अब कई बच्चे चंचल होते हैं. Some children are naughty. कई बच्चे शरीफ होते हैं. They are not naughty. तो उसके हिसाब से भी आप HbA1c decide कर सकते हैं. Dr. Jubin, this is this singer from Kerala, Yesudas. So he said, "Chanchal si nadi, Chanchal jaisi Tista." The Tista flows in Sikkim. So, ab Chanchal nadi hoti hai. So you see, at each and every bend, the river has a life of its own, a different life, and that is what we experience during adolescence, during transition. So you flow with the current. जैसा बच्चा flow कर रहा है, उस हिसाब से आप HbA1c भी up down कर सकते हैं. So thanks, Anshu ji, for asking this question. But Samrita ji, let's go back to solution statements. Many people are fond of saying that India is a resource-challenged country, limitations हैं. Dr. Abid Rahman हैं हमारे साथ from Somaliland, वहाँ पे उनके अलग challenges हैं, अलग limitations हैं. But कोई ठोस चीज दें. What is it that you are able to do in Ludhiana within limited resources, which is actually helping our patients and their families?
Yes, sir. So, sir, I follow 5 principles. So, these 5 principles actually allow you to manage this transition care very easily. So, first, I already discussed this effective communication. So, you need to think like them. You can go to extremities. You can just think what can the kid like do, कैसे वो शैतानी कितनी हद तक कर सकते हैं, and actually you have to gain their confidence that it is you with them. It is like they don't have to always answer, like they can obviously discuss with the doctor, but you have to be a friend to them. So effective communication is the first. The second thing which I thought is actually knowing what they know about themselves. So assessing the self-care and knowledge. Are they are the ones who are administering insulins? Are they checking the sugars on their own, or the family is behind them? Are they aware of the fact what diet has to be followed or what timely eating has to be done? So assessing the self-care knowledge will obviously ease this process, because here the family, most of the times the family is responsible. They are after the kid to take the injection, to eat on time, to not sleep late, to not eat snacks and everything. So the second thing is assessing self-care, and self-care knowledge will be necessary. The third thing during transition is to educate and transfer of new skills. So during transition, as Dr. Jacob also said, they start driving, they start with this alcohol, and they start with this sexual thing is always new to them. How to handle stress, how to handle the peer pressure. not to actually become too conscious about their diabetes. So we can add new skills to these terms, which are obviously introduced in transition. The fourth thing is team based approach. So team based, generally, if we include, we can go for an adult endocrinologist in the team, a transition coordinator, a diabetic educator, a psychologist. And it would be very helpful if we could get the information from the previous pediatrician they were actually referring to. So they would also know quite better how the child is, how the nature is. So it would be very helpful for us to know the history of the child from the previous pediatrician. The fifth and the last would be to assess their psychological needs. So obviously, we should always get to the point that they are not taking this diabetes management too seriously. Like, they should be aware, they should be responsible, they should know how to handle things, but they should not be calculative. The whole day they should not be thinking about this, because I did counsel one patient. So his HbA1c was perfectly normal. He was exercising 2 hours a day, he was eating very well, and but he was not happy. He was just always frustrated. So at the end, we came to know that yeah, he's being very calculative. After every 1 hour, he's calculating, if I will do this, my sugars will get high. If I'll do this, my sugars would get low. So assessing what actually their major concern in diabetes is would be very really helpful.
Many C's coming across from what you said. The first is communication. So
Yeah.
we need to communicate with the child. Vinayak Sharma ji has also joined us. And Dr. N.S. Sharda sir says कि आधार कार्ड भी रखें, emergency contact number, सब numbers उसमें होते हैं, साथ में disease भी उसके साथ ही चिपका लें. Maybe you can put a sticky note
Right.
to that. तो एक तो हो गया communication. दूसरा confidence building. Communication का कोई फायदा नहीं है. The way Dr. Jubin said, you may think you are a very good orator or a good communicator, but वो आप कह रहे हो ना, actually सामने वाले से पूछना चाहिए कि आपने कितना अच्छा communicate किया. So he or she will decide. So communicate properly, gain the confidence of the child. So the second C is confidence. तीसरा assessment of care, self care, self knowledge. इसको assess तो करें, देखें कहाँ से चल रहा है. एंड फिर एक जो सी जो सिमता जी ने फोकस किया, दैट इज कॉम्पिटेंस बिल्डिंग. Competence building will be of two types. One is psychosocial management. The child is being bullied at school. School में छेड़ा जा रहा है, छेड़खानी की जा रही है. How to handle peer pressure, कैसे हैंडल करें. और अगर आप खुद नहीं हैंडल कर सकते तो इसी बहाने सीख लें, तो बच्चे को भी सिखा दें, खुद भी सीख लें. And the second would be health related, like how to check glucose, how to go to the hospital for an appointment alone, how to take insulin. So that would be a different type of competence building. जो दो और सीज जो डॉक्टर साहब ने कहे हैं, दे फोकस ऑन इंटीग्रेटिव केयर, एंड द फर्स्ट इज कोऑपरेशन एंड कोलैबोरेशन. सो कोऑपरेशन एंड कोलैबोरेशन बिटवीन ऑल हेल्थ केयर प्रोफेशनल्स, जो पीडियाट्रिक्स वाले हैं वो भी, और जो एडल्ट केयर वाले वो हैं वो भी, और ट्रांजिशन वाले तो हैं ही हैं बीच में. एंड जो हमारी स्ट्रेटजीज और जो हमारे टारगेट्स होने चाहिए, आवर टेक्निक्स, आवर टूल्स, आवर टारगेट्स, दे शुड फोकस ऑन कॉम्प्रिहेंसिव और बैलेंस्ड केयर. तो जैसे सिमता जी ने कहा, वो बच्चा था हु वाज ऑलवेज कैलकुलेटिव, लाइफ का मजा ही खत्म हो गया. तो इन मोस्ट ऑफ इंडिया यू कैन यूज एनालॉजी ऑफ लॉर्ड बुद्धा कि अमन शांति से रहें और मिडिल पाथ फॉलो करें, एक्सट्रीम ना करें. भगवत गीता का भी आप श्लोक यूज कर सकते हैं, ये 17वें या 18वें चैप्टर में है, जिसमें भगवान कृष्ण एक्चुअली ये कहते हैं कि अगर आप सात्विक हैं, इफ यू आर इन इक्विपॉइज, तो आप सात्विकता, राजसिकता और तामसिकता, यू विल एक्सेप्ट ऑल ऑफ देम विद इक्विपॉइज. तो कभी कभार अगर हमारा बच्चा राजसिक हो गया, दैट मीन्स फोकसिंग टू मच ऑन ग्लूकोज, बीइंग हाइपर एक्टिव, तो जायज है, चलेगा. कभी कभार तामसिक हो गया, लेजी, नॉट वांटिंग टू चेक ग्लूकोज, नॉट वांटिंग टू एक्सरसाइज, तो भी चलेगा. That is the definition of Satvikta. Satvikta means equipoise or a balance. So you can use these kind of analogies from religion. Supposing बच्चा कहता है जी सर मैं तो एथिस्ट हूँ, और खबरदार जो आप रिलीजन की बात करो मेरे साथ, तो ठीक है, अभी we will not talk about healing and harmony, but let's talk about the तीस्ता नदी. So तीस्ता नदी देखो कितनी चंचल है. Does the तीस्ता think before it bends and turns? Does the तीस्ता think before it decides to be still or not? No, it just enjoys life. So you also enjoy life like that. So
Yeah.
something or the other you will be able to find which resonates with that child who is going through this transition phase. Dr. Jubin, your comments on this?
No, so I think I complete. अभी आपने तो उसको बहुत अच्छी तरह सब C's में डाल दिया, but the principles remain the same. तो hello.
Yeah, carry on, Dr. Jubin.
Yeah, so the principles remain the same. I mean, you said effective communication. Essentially, you are now assessing what the self-care knowledge skills of the child is. You're transferring old skills and the new skills to the child, and then obviously all this happens as a collaboration team. And finally, I think very important is this addressing the psychological issues as well. Now, there are various ways you can.
We are missing Dr. Jacob perhaps, but Srimita ji, could you continue? Dr. Yogesh has joined us. Good evening to him. Dr. N.S. Sharda sir पूछ रहे हैं, what about other chronic diseases? So in your work in Christian Medical College Ludhiana, do you handle other diseases as well apart from diabetes?
No, sir. I work only for endocrine and diabetes unit only. So, but other chronic diseases also has a similar pattern only. Mostly because obviously it's chronic and you need a multidisciplinary approach for managing it. So your psychosocial needs should be addressed accordingly.
Even if it is, let us say, hypothyroidism, तो पहले mother in charge होती हैं. So the mother decides, whether she will give the thyroxine tablet in the morning or at night, what time. But कभी ना कभी तो बच्चे को charge लेना ही है. So that is also part of transition. Dr. Vipin Bhandula, pediatrician है from Himachal. Dr. Narinder Singh has also joined. Dr. Vipin कहते हैं कि you should make a group of type 1 persons living with type 1 diabetes, health educators, doctors, endocrinologists, and we share our experience with each other. So you should have these cross connects, these cross communications, so that we can learn. And point well taken, sir. Actually, ये होना चाहिए, and the patient voice, the public voice must be heard, because finally हम उन्हीं की सेवा में हैं. So we should follow that.
I would like to add, sir.
Yeah.
Actually, I have made a group for these type 1. So I just like to add one more thing. So connecting these kids when they have hobby. Most of the kids I counsel doesn't have a hobby. They are just following a routine. Because they have made diabetes, they have paid so much attention to it that they have just forgotten to live their life. So hobby can be one more thing that can help, that can actually help the child to focus on some extracurricular activities or having a hobby and books. These can be also become a best friends during this transition.
ये बहुत ही अच्छा आइडिया, एंड थैंक्स फॉर हाईलाइटिंग दिस. हमारा एक बच्चा अब तो बड़ा हो गया, ही इज 20+. तो कोविड के टाइम पे थोड़ी सी दिक्कत आई, ज्यादा दिक्कत आ गई, एंड ही गॉट दिस ब्लैक फंगस. तो उसके बाद तबीयत तो खराब होनी थी, बट ही रिकवर्ड फाइनली. एक आंख में थोड़ी सी दिक्कत रह गई, एंड हाउ दैट बॉय फाउंड मीनिंग इन लाइफ वाज, वो हाफिज बन गए कुरान शरीफ के. सो ही हैज मेमोराइज्ड द एंटायर कुरान शरीफ. So, जिसको और कोई डिसेबिलिटी कह सकता है कि एक आंख से पूरा नहीं दिख रहा, he has converted that into an ability. So he used his brain and he memorized it. And I feel so proud when I see him कि वो हाफिज बन गया कुरान शरीफ का. And I don't even know one ayat, but he knows all of them. So he is superior to me. So that is another hobby. So certainly कुछ ना कुछ मिल जाएगा.
Yes.
In इतनी बड़ी दुनिया है, and there are so many things to do. Thanks, Dr. Vipin, for highlighting this. आई एम वेरी श्योर अगर आपके कोई बच्चे हैं विद टाइप 1 डायबिटीज हु नीड दिस काइंड ऑफ बडी सपोर्ट, तो सिमरिता विल बी हैप्पी टू हेल्प आउट. प्लीज फील फ्री, वेदर इन दिस KKMed talk or later on, just to share their numbers, and we'll make sure they reach Ms. Chawla. Nutritionists should also be involved, Dr. Vipin कह रहे हैं, in transition care. Right. And that's true. गीता अग्रवाल जी भी आपको ग्रीट कर रही हैं. So today it's 8 now, and we've discussed so many things about transition care. Dr. Jubin was with us. He is a professor of endocrinology. He has worked in the United Kingdom and also in North India, in South India. So जो उनकी एक्सपर्टीज है, उसके साथ आज हमें एक्सपर्टीज मिली मिस सिमृता चावला की। एंड जैसे कि मैंने कहा, यंग इंडिया, ब्राइट इंडिया, स्माइलिंग इंडिया को देख के बहुत अच्छा लगता है। वी फील सो हैप्पी दैट आवर कंट्रीज, आवर कम्युनिटीज फ्यूचर इज इन सेफ हैंड्स। स्वप्ना जैन जी एक रिक्वेस्ट कर रही है मैडम आपको, चावला मैडम को, कि लेट्स डू अ सेशन ऑन हाउ टू मैनेज एंड बैलेंस दीज सिचुएशंस। सिचुएशन क्या थी कि स्वप्ना रिक्वेस्ट हर डैड टू चेक हिज ग्लूकोज अगेन एंड अगेन। तो पापा रेजिस्ट करते हैं, जैन साहब रेजिस्ट करते हैं, कभी वो इंसुलिन लेना भूल जाते हैं, कभी टैबलेट लेना भूल जाते हैं, एंड देन स्वप्ना बिकम्स ओवर प्रोटेक्टिव, ओवर कंसर्न्ड। तो शी डजंट नो हाउ टू बैलेंस, यू नो, भी कब इंटरवीन करना है और कब स्टेप बैक करना है। सो just like Dr. Utsav said, transition is not only at the adolescent level, it is also at the geriatric level. So we do need not one but many KK Med talks on this. So certainly we'll do. So we'll do that. But it's been great, Samrita, having you with us, and also Dr. Jubin the. Prateek is with us backstage. Prateek, could you please show a certificate of appreciation for both our speakers? Thank you, Samrita. Thank you so much for being with us. We've learned a lot from you today, and also for Dr. Jacob as well. And he's back in time.
Yeah, sorry.
Thank you. No, that's fine. You're right in time for your certificate, Dr. Jacob. You're on time.
Thank you very much.
Yeah. Dr. N.S. Sharda sir कह रहे हैं कि you learn from the Bhagavad Gita, you allow the patient to speak out his or her problem. So let the patient speak. In Bhagavad Gita, first Arjun spoke. Then you appreciate the concern. You say that I understand what you're saying. I have sympathy, empathy, compathy with you. And then you suggest. And at the end, you have to be patient-centered, because even in the Gita, in the last chapter, this shloka I remember, 1863, what Lord Krishna says is, I have taught you everything there is to teach. Now it's up to you. You decide. So this advice from Dr. Sharda sir, we'll all take. This is person-centered advice. Before we leave, Dr. Jubin, final comments from you, please.
So I think my final comment is, we assume that transition is an expensive thing, because in the West, it includes transition clinic, specialist transition nurses. But I don't think transition needs to be expensive. It can be, like Smrita said, a simple buddy. It can be just a young adult support group. The same principles will apply there. It can be just a transitional coordinator. Now, Smrita is not a full-time coordinator. She has other jobs. So it's not that she's only doing transition. This is a part-time job, but a full-time, she's earning her money through other activities. So there are simpler ways, but the principles will remain the same. And I think even in our country, we can provide transition care to all children going through transition.
Thanks. And Simrita, final comments from you before we conclude for today.
Yes, sir. That's it. The type 1s, being type 1 is again a very normal thing. As for my experience, I will feel there was time I used to have a lot of fear of complications of the thing that I cannot do anything. But one thing I will definitely add, if you get a right direction, if you have aim to in life, and if you have right people, like, your motivation should be one thing that will help you through getting through diabetes. And it is actually easy. It doesn't seem so, but yeah, right people, books, hobbies, everything you can find out, and you have to have an aim in your life, because diabetes is not everything.
Diabetes is not everything. Thanks for that. Dr. Vipin says empathy is something that is important. And if we all empathize with each other as human beings, certainly we'll become a much happier, a much more harmonious, and a much healthier society. KK Med Talks का यही उद्देश्य है, and that is to spread health and healing through knowledge, through information. और रोज KK Med Talks आपकी सेवा में होता है. मैं आपके साथ होता हूँ हर सोमवार और वीरवार. And we'll continue on this journey together, on this journey of exploration, of learning, of health. Thanks, Dr. Jubin ki bhi finally transition from darkness to light.
वो last minute में आपने कुछ बोला और light आ गई.
अरे डॉक्टर विपिन कह रहे हैं दीप से दीप जलाते चलो, तो दीप से दीप जलाते रहेंगे, और ये शम्मा इल्म जो है, द फ्लेम ऑफ नॉलेज, वो हम जलाते रहेंगे, चाहे पीछे से लाइट हो चाहे ना हो. सबको शुक्रिया, धन्यवाद, मेहरबानी वंस अगेन. मैं आपको फिर मिलूंगा अगले सोमवार. हमारी स्पीकर होंगी डॉक्टर संगीता वर्मा. She's a pathologist from Panchkula, and she'll be talking to us about simple tests. ये जो आप इतनी बार टेस्ट कराते रहते हैं, TLC, DLC, हेमाटोक्रिट, ESR, इनका मतलब क्या होता है हीमोग्लोबिन का? तो ये वाला दीप जलाएंगे शम्मा इल्म का अगली बार, और तब तक आपसे इजाजत लेते हैं. शुक्रिया, शब खैर और जय हिंद.
Thank you, sir.
Bye bye. Good night.
Thank you.